Good afternoon. Thank you for joining the We Can Educational Series. Today, Dr. Lynn Sheets will address the topic of abusive head trauma. Dr. Sheets is a child abuse pediatrician at the Children's Hospital of Wisconsin in Milwaukee. She is a professor of pediatrics at the Medical College of Wisconsin and medical director of the Child Advocacy and Protection Services program. The handouts area includes a PDF of today's slides, as well as a PDF with details on the following housekeeping items. If you are viewing with a group, make sure to send names and email addresses of all attendees to Kathy Artolini for attendance tracking. In order to obtain continuing education credits for today's session, you must register online and complete your evaluation. To ask a question, you can use the question pane on the control panel. These questions will be addressed at scheduled breaks. For a list of future topics, please visit our website, wichildabusenetwork.org. And now we'll proceed with today's presentation.
Welcome, everybody. This is Dr. Lynn Sheets, and as Sarah said, we're going to be talking about abusive head trauma today. I have some built-in breaks, and we'll be addressing questions if they arise at those breaks. I do not have any relevant financial relationships to disclose or conflicts of interest to resolve. And as usual, this is a topic that can be pretty hard to hear and involves some somewhat disturbing scenarios, and I think probably only one slide or one photo that's a bit disturbing. The cases that I'm using in this presentation have been de-identified in a variety of ways, and then I also want to make sure that you know I'm not providing legal advice. So I will go through the scope of the problem and then a case study, talk a little bit about the biomechanics of abusive head trauma, symptoms and injury, and then outcomes. I probably will not have time to talk very much about prevention, but some of the prevention strategies are woven into this presentation. The amount of data at the beginning of this presentation is actually small, but I have included a little just to sensitize you in terms of the scope of the problem. Many of you may know that head trauma is the leading cause of death and disability among abused infants and children, and about half of all brain injuries in children under 1 year of age are due to this type of severe abuse. At Children's Hospital, we keep annual data of the number of abusive head trauma cases, and as you can see, over the years, it has remained fairly steady at an average of about 20 per year. In 2009, the American Academy of Pediatrics made a policy statement that helped to clarify what people used to know this as, which was a shaken baby syndrome. In that year, a decision was made to make this clarifying statement because the common terminology of shaken baby syndrome did not accurately portray what we know about the mechanisms involved in causing this. In other words, it presumed that shaking was the mechanism, where in fact shaking, slamming, throwing, kicking the infant's head, basically rotational injury with sudden acceleration, deceleration, was the true mechanism in these cases, period. For that reason, the American Academy of Pediatrics issued this statement to start changing the terminology that was used. So what is abusive head trauma? I think most of you know that it's a type of very severe physical abuse, and in fact, it's the type of physical abuse that always leaves at least some permanent injury, at least as far as we know. Some of that permanent injury may not be detectable, but if we could do the study where children subjected to this type of injury then were compared to what they would have been had they not been subjected to this kind of injury, we would likely see some changes in that life course trajectory. In other words, the child will never be the same again after having this very severe type of primary brain injury, even in milder cases where the child may seem to be okay. It is seen almost exclusively in little kids, basically infants and young children up to age 5, because the child has to be small enough that they can be held, shaken, and slammed, or in some way propelled in a sudden way as to cause this injury or the scope of injuries. It does involve severe forces of rotation, acceleration, and deceleration. And so many of these cases have impact involved in them, and we'll be talking a little bit more about the role of impact later in the presentation. The severity of the injuries that we worry about the most are the brain injuries, and those result because of these angular or rotational forces. They're very much like a very severe concussive type forces. So concussion in older kids usually comes about through some type of impact or sudden acceleration or deceleration, like in a motor vehicle crash. But in infants, you might wonder, how could this happen if there's not impact? Well, think about an infant's head being flung back and forth. At some point, that infant's head, as it's moving forward, stops in the trajectory, often when the chin hits the chest. And so even the cases involving shaking without the child being thrown, kicked, slammed, or other types of obvious impact, even in those cases, there is a sudden stop and start nature involving essentially impact, often onto the chest or onto the back of the infant. So this is a case that I think some of you may be familiar with, as I've used this case in some of the sentinel injury lectures that I've given, but this was a little 2-month-old who I saw early in my career, and this little guy had a cheek bruise on his left cheek that was seen by a visiting nurse 2 days before. We know that bruising in young infants before they're able to cruise is abnormal. It's unexpected. And in fact, bruising or a mouth injury or a little burst blood vessel on the white part of the eye not related to birth is considered a sentinel injury in pre-cruising infants. In other words, it should always raise a concern and at least thoughts about child physical abuse, and often it should lead to reporting and screening for occult injuries or deeper injuries in the body, such as skeletal injury. So children not yet cruising shouldn't be bruising, and this now has been reinforced and validated through multiple research studies, and the American Academy of Pediatrics in their most recent statements around physical abuse in infants cautions that pediatricians need to be alert to any bruising or significant injury other than a scratch in a pre-cruising infant. Cruising, if you don't know what that means, is that the child is able to pull to a stand and take a few steps while holding on. It typically happens when a baby is around 7 to 12 months of age. And that's where we start to see occasionally accidental or unintentional bruising. So just a reminder on a topic that hopefully you've heard before, when considering a bruise in a child, think about, is the child a pre-cruising infant? Because if so, a certain amount of workup or evaluation needs to occur, and usually reports to CPS and law enforcement need to be made. You should also remember that most injury incidents involving even older children usually cause only one bruise. And so seeing more than one bruise, even on a mobile infant, from one injury event would be a little unusual. Most accidental bruises in mobile infants, those who are able to walk, run, and jump, are on the front of the body, often over bony prominences like the forehead, the knees, and shins. Bony prominence is where the bone is right underneath the skin. And then accidents rarely cause any bruises in mobile children on the ears, the neck, or the genitals. And even in other places like the buttocks, the upper arms, the back of the legs, and the feet are uncommonly bruised in accidental injury. So this is that same little guy I showed you who had the cheek bruise when he was initially seen by a visiting nurse. Just 2 days later, he presented. He did not get seen at this point when he had just the bruise on his cheek, and stayed in the home. And then just 2 days later, he presented with symptoms that raised concerns for abusive head trauma. And indeed, he had injuries that were diagnostic for abusive head trauma. At that time, he had a skeletal survey, and that showed healing fracture of a rib and a healing fracture of his femur, which is the thigh bone. Had he come in just 2 days before when he had this sentinel injury, we would have done the occult injury screening, which would have included a skeletal survey. And his abusive head trauma that happened 2 days later likely would have been prevented. So this points to a key prevention strategy in abusive head trauma, and that is asking about and on exam or even just looking at babies, noting sentinel injuries. This was a 2-month-old twin who had this linear bruise on the calf of the leg. And this did get reported. This child got protected, and ultimately this child did well as far as I know. This was virtually diagnostic for abuse in this infant. There was no underlying bleeding disorder. We also know that twins are at markedly increased risk of abuse. And I've referenced a study done by Dan Lindberg, but whenever a family is stressed, and lots of stresses can do this, they are at higher risk of getting frustrated or angry at a baby who is often, the triggering event is crying, and then is at risk for abuse. So other risk factors are any type of stress in the home, and that includes poverty or financial stress, any type of relationship stress, intimate partner violence, domestic violence. Many caregivers who are at higher risk are young or immature. They may have unreasonable expectations of the baby. A common scenario that we see is that young or immature parents are playing video games and get frustrated or irritated at a baby who's crying and interrupts their play, and ultimately the infant gets severely injured, whether it's abusive head trauma or other types of physical abuse. Other risk factors include social isolation. Interestingly, a first child is at increased risk, and then a non-related paramour or significant other living in the home as an intimate partner increases the risk of fatal child abuse. If you don't control for confounders, it increases it 50 times. If you control for confounders, it still increases the risk of fatal child abuse 6 times. Risk factors that are more related to the actual parent or caregiver are mental health or substance abuse issues, caregiver having a history of violence in the past, such as experiencing abuse as a child, any type of AODA issues or mental health issues. I've mentioned multiples, and basically anything that makes the infant hard to care for. So a temperament where they're crying more than normal, or infants with chronic medical problems, premature infants or low birth weight infants, infants who have some type of opioid addiction, so the neonatal abstinence syndrome infants. These are all infants at higher risk because of partly infant factors and also caregiver factors. pretty uniformly, the combination of some of these risk factors combined with the trigger behavior, which in abusive head trauma and most infant abuse is crying. So crying that annoys, crying that irritates, crying that's high-pitched, crying that interrupts what the parent is doing, crying that awakens a caregiver. So the trigger event is usually crying, and then ultimately the infant is shaken, slammed, kicked, abusively, head injured. So I'm going to pause just one moment and just take a look at our question pane, and not seeing any, I'm going to continue. So a quick review, I've mentioned sentinel injuries, but this is so important in preventing not only abusive head trauma, but also other severe types of abuse, physical abuse of infants. So sentinel injuries are any bruise or mouth injury or the little bruise in the whites of the eyes that occur in a pre-cruising infant. They should raise a concern for abuse, and if they're recognized, we have an opportunity to get services in and develop protective plans or other strategies that might prevent escalation of the violence against the infant. In abusive head trauma cases, our research showed that the presence of a sentinel injury was in about 30%. So this is the kind of injury that we're talking about. I mentioned bruises, but also mouth injuries. And so this baby has a little injury underneath the tongue on what's called the frenulum of the tongue. That's that little bridge of tissue that connects the base of the tongue to the floor of the mouth. You also have a frenulum underneath the upper lip and one underneath the lower lip, which is not seen here. The frenulum can be injured in children who are mobile, who are able to walk around, if they fall onto something that pokes or injures this part of the mouth. But in a pre-cruising infant, this is never normal, it's never expected, and it should always raise a concern about child physical abuse. It can come about through a caregiver who gets frustrated and rams or forcibly inserts some type of object or a finger or something into the baby's mouth, causing this injury. So what about the size of the injury, either in the mouth or the size of a bruise? Does that really matter in a pre-cruising infant? And the answer is a resounding no. This was a baby who was a victim of abusive head trauma and had this tiny little bruise in the mouth, right here between the lower lip and the gum line. And this baby, this single little bruise is a sentinel injury, and if seen in even a well baby, should raise concerns about abuse and should lead to a full workup for occult injury or injury surveillance, which in a baby who's under 6 months of age would mean a head CT, 2 parts of the skeletal survey, some lab work, a workup for a bleeding disorder, because we certainly don't want to miss a medical cause for this, and urine for screening for exposure to illicit and prescription drugs. Here's an example of a sentinel bruise on the cheek of this 3-month-old, and in a 2-week-old with this forearm bruise, which is much easier to see actually if you put pressure on the skin, because the bruise right now is a little bit concealed since the skin is already pink. But if one just puts pressure on the bruise, you can actually push out the blood or the pinkness of the skin, and it makes the bruise visually pop. And we call that blanching the skin. There's another example where there's actually, you don't really see the bruise on the front of the ear very well, but if you look at the back of the ear, you can quite easily see a bruise on the back of the ear. Another example is on the sole of this baby. These are very important injuries, and if we detect them, we have an opportunity to prevent more serious abuse like abusive head trauma. If you want to learn more, and I failed to include this in your handout, so if you want to learn more about sentinel injuries, there was a collaborative effort to develop this 25-minute module that was really designed for non-medical professionals, but also would be appropriate for parents or daycare providers about why sentinel injuries matter and what they are. It is publicly available through the Child Welfare Partnership at UW-Milwaukee, and I've included the link on this page. So the theory of injury for infant abuse is this, and that is the infant's distressed, or is just going through normal developmental crying, which infants do. It peaks around, if it's normal, it usually peaks around 6 weeks of age and then starts to taper off. But some infants, even normal infants who have nothing wrong, will cry many hours during the day. This is really a normal developmental stage, but in the hands of a family with risk factors and probably some complexity that we don't fully understand, caregivers will sometimes then resort to abuse, and about a third will cause sentinel injuries by poking the infant or hitting the infant, causing bruising or mouth injury, and then others will continue to escalate in their violence and ultimately, in some cases, result in abusive head trauma where the infant's shaken, thrown, or slammed. So what about infant crying? I've mentioned it's normal. I've put some references in your handout. I don't want to spend a great deal of time. We actually have one of the weekend lectures on infant crying, but we know it plays a major role in why infants are abused. Feel free to look at those references. When we performed the sentinel injury research, what we found is for the infants with abusive head trauma, most of those infants, well, we saw the greatest number of those infants peak here around 4 to 6 months was the kind of the average age. And when we talked with those caregivers, about 30% had a previous history of a sentinel injury, and those sentinel injuries were occurring or peaking around 2 to 3 months of age, which raises the issue. Wait here. I think it reinforces the topic that I just introduced, that if you're seeing crying normally peak at this point, around 6 weeks of age, then we see infants getting poked, prodded, hit, causing sentinel injuries, and then at least in some progressing to abusive head trauma. We want to prevent this progression by detecting sentinel injuries early. So again, I'm pausing for questions and looking at the question pane and seeing none, I'm going to continue. So what about the trauma event? I've mentioned that the baby is perceived, and not necessarily actually is, but perceived to be crying in some irritating way. So persistently or high-pitched or an annoying behavior, or will not calm down. And the caregiver grabs the child, often by the arms or around the chest. Now, you may wonder why it is that we don't see fingertip contusion on the child if they're being grabbed and shaken, slammed, or thrown. And the answer is that children's skin is so compliant, it's so elastic, that you can actually get internal injuries but have absolutely no bruising on the surface of the skin. We commonly see this in children with acute rib fractures, so multiple rib fractures that came from squeezing or even impact to the chest, and those children rarely have any bruising bruising on the chest. And so we occasionally will see fingertip contusions, but in most cases we do not. And then the child is shaken or violently moved back and forth or slammed, kicked, or thrown, something with sudden acceleration, deceleration, and then the brain, uh, these kind of damaging or injuring forces are then exerted on the brain and the eye, resulting in the injuries that we see. And I'll talk a little bit about that in a moment. So this is just an animation showing the nature of what this injury, how these injuries might be caused. Some may not involve any shaking, but may involve just slamming. Almost, I can't envision a situation of shaking that wouldn't involve sudden starts and stops. So all of these have sudden acceleration, deceleration as a component, which results in rotational injuries or rotational forces exerted on the brain and on the eye. So how do these severe rotational forces actually cause the injury? Well, if you think about the brain and the contents of the head moving forcibly back and forth, tissues tend to move at their own rates depending on the density of that tissue or the mass of that tissue. So if you think about maybe a layer cake, which I have depicted here in a little cartoon, if you think about the frosting layer might have a little bit different density than the cake itself, which would have a different density than the filling of the cake. And if you could shake or fling this cake back and forth, likely what you would see is some splitting along those different layers, the essentially interfaces, under the effects of those rotational forces. So the same is true in the infant or young child who has these kinds of forces exerted on them. We know that if forces such as an impact or a slam is used, that it can increase the amount of force exerted upon the brain and the eyes. And so certainly at least many, if not most cases, involve these sudden acceleration, deceleration, often from impact combined with shaking. So can shaking alone cause abusive head trauma? This is a common court question, but becomes less relevant if you think about how a child could get injured by shaking. Going back to that example I mentioned, if a child's head is flung back and forth, the head is suddenly stopping and then starts moving again. So you have that sudden acceleration, deceleration, maybe even with impact onto the chest or back. We also know through some research studies that even just a repetition of two sudden acceleration, deceleration events, that the injury threshold, in other words, the amount of force needed to cause brain injury, drops. It decreases for that second impulse. So that we know that when the child is being shaken or slammed, that first shake may have fairly high thresholds of injury where it takes a lot of force, but then the injury to the cells in that first shake make the child and the brain more susceptible to injury in the third shake and then in the fourth and so on. So we know that the repetitive nature increases the risk of severe injury. We also know that, of course, impact increases the risk of severe injury. So what parts of the head are vulnerable? Well, I've included it here in this slide, but basically I've mentioned the brain. We know that the tissue interface where the brain and the blood vessels covering the surface of the brain, that interface is another place where we often see injury. And then the inside of the eye, where the jelly or the vitreous inside the eye moves differently than the globe itself and under the effects of these rotational forces that are severe, likely is the cause of the retinal hemorrhages, which is the bleeding inside the eye that you cannot see just from looking at the infant. So this is just an illustration of that. And the normal infant, you can see the brain, and there are blood vessels on the surface of the brain. There's a large venous sinus where the blood is draining, going back to the heart here in the center along the sagittal sinus. And this is a kind of a cross-section showing that if there's movement where these blood vessels are bridging and going up into the sinuses, of which there are more than just this one, that you can get actual tearing of the blood vessels. But we also know that the dural border cells here are vulnerable to tearing, and that the tearing from rotational forces can happen at that level as well. So this is just a very simplified illustration, but if this child is shaken, slammed, thrown under severe force, you can get what's called a subdural hemorrhage or hematoma, and that's illustrated here. There is an actual slide of that that's an autopsy slide of that that's coming up. So if you don't want to see actual tissue, you might avert your eyes for this next slide. So this is just showing what I mentioned to you. These are the blood vessels on the surface of the brain. You can see lots of them. And then there is a little bridging vessel that's well seen. And these are one source of where the forces of severe rotation, sudden acceleration, deceleration can cause these basically to tear apart or to shear and cause bleeding here on the surface of the brain. That can happen in the subarachnoid space, but it can happen in the subdural space. So there are various layers here where we can sometimes see that bleeding. So this is just a cross-section, as you can see, of the brain, and you can see the white matter and the gray matter, or the blood vessels, the various membranes over the surface, and the skull. And the head is at rest in this picture. But if you put severe rotational injury into place, you start to see this movement at the tissue interfaces. Sort of like if you took an egg and break it into a bowl. And if you just move that bowl slowly back and forth, the yolk and the egg white move at the same rate as the bowl. But if you do that much more quickly, what you'll see is you can get a situation where the egg, and particularly the yolk, is moving in one direction and the bowl in the opposite direction. And that's because, again, under a given force, tissues with different masses move differently. And so you also get just kind of this whipping effect, and it causes stresses and strains, or what we call shearing injury, at these tissue interfaces. So that's where we see the injuries in abusive head trauma. We can also see injuries at those locations in severe motor vehicle crashes where the infant or young child is not restrained. We can also see them in like falls out of very, very high elevations where there's a sudden deceleration with great force, such as a fall out of a multi-story window. So what does this do? This causes a diffuse primary brain injury, and that just means that you have injury throughout the brain because you have the gray matter and the white matter moving differentially. And so you can see shearing here, but sometimes in more mild cases, nothing shows up in the brain as far as injury, at least on x-rays. But clinically, at least by history, we know that there was a primary diffuse brain injury because of the way the child behaved. The most mild primary diffuse brain injury that you are probably familiar with is a concussion, so like in a soccer event. A concussion is immediately symptomatic. It usually has a completely normal MRI and head CT. Usually you can't see anything, but it represents diffuse primary brain injury. And that comes from the same kind of shearing effect that's illustrated here. So we see in these kids this, as I've called it, primary brain injury, and that means it's coming directly because of the severity of forces and the type of forces in the trauma event. And then we often, not always, but we often see secondary brain injury, because when the brain gets injured, then the baby or young child may quit breathing normally, and the whole controls for the breathing and the heartbeat and blood pressure and maintaining adequate blood supply to the brain is injured. And so those control factors, which are from the brain, are injured because of the primary trauma event. And then you get poor blood circulation, poor oxygenation to the brain, and then you get a lot more tissue injury because of this low oxygen, low blood supply, and it begins kind of a really toxic downhill cycle. Think about if you've had a sprained ankle. You know, when you have a sprained ankle, initially you have a lot of tissue injury, and then if you don't control the swelling through your rice, so you're using the ice and rest and cold and elevation. If you don't do that, you'll get swelling, and that then results in additional injury to the ankle. The brain is even worse because you have actually the nervous system that's injured, and so the nerves themselves are injured and resulting in swelling and this toxic cascade. So I'm going to pause, look at my question pane, and seeing none, I'm going to continue. So what about symptoms? Well, I've alluded to some of these already. The way we know about symptoms are because of like motor vehicle crashes that could have similar injuries. So we know about a lot of unintentional injury that has similar types of forces. We also know from confession cases where people who have done this to an infant have described what they've done and what they saw after they did it. And so that's how we know this. But you should keep in mind that in some cases, the baby may continue to breathe, and if they don't get medical care, at least in some of the milder injury cases, although none of these are mild injuries, but the ones that are on the milder spectrum may just seem sick for a few days and then start getting better on their own. Carol Jenny published this case series in 1999 looking at abusive head trauma cases when they came in and looking how often medical providers actually missed these cases. And it was in about a third of the cases that they were missed. This is an example here. This was a 5-month-old who supposedly bumped the head against a chair leg. When she rolled over, she cried and then she was fine. She took a long nap and then had some vomiting later on. About 4 hours later, the mom came home and the baby did not seem her normal self. She wasn't as alert and she was still vomiting. So the mom took the baby to the emergency department but was frustrated because she had a 5-hour wait and still the baby hadn't been seen. The triage nurse in the emergency department did not recognize that this was abusive head trauma because, as you know, kids sometimes vomit from like viral infections like a stomach flu, and so nothing in particular alerted the triage nurse that this was something different than the 100 cases that they had already seen of the stomach flu. So the baby seemed better the next day, but then vomited again a couple of days later and was brought back in. And at that point, the head CT was done. Unfortunately, because the baby looked so good at that point, the baby was actually sent home before the results of the head CT were known. And the head CT was reviewed. It actually showed the bleeding on the surface of the brain. And then the baby still still seemed fine, but was brought back and then had the workup. And that workup showed lots of other injuries, including multiple retinal hemorrhages and a healing rib fracture. Ultimately, this case led to the father pleading guilty, and he was ultimately sentenced to 4 years for shaking, slamming, or throwing the infant. So the symptoms are what I've already alluded to, breathing problems in many cases, sometimes a seizure, sometimes just decreased alertness or not, the eyes not being quite as bright or as alert. In severe cases, the pupils are unequal, or the baby may appear to gaze in one direction or another, sometimes because of a seizure. Some of these babies will have just a high-pitched or different cry, or pained cry is what sometimes they're described as having. Many of them will sleep more than normal, but some will become more irritable and have more prolonged crying. Decreased interaction with the caregiver, sometimes poor feeding or vomiting. Sometimes the soft spot will be bulging or tense. Sometimes they are actually dead at the scene or comatose, or die shortly after they present for care. This is just another case of a missed case of abusive head trauma. You can start to see a pattern here because sometimes these babies look just sick, and somebody who knows what happened is concealing the real history of what has happened. So the medical provider thinks that it's the common viral illness that's going on in the community. So this was a 5-month-old who was being seen for a well baby check, and was noted to have be underweight and have bruising of the scalp, which you'll see in the next slide. This was a case from several years ago. This is a sentinel injury. This should prompt a workup and concerns for abuse in and of itself. There was somewhat of a workup, and the liver enzymes were noted to be abnormal. There was this history of vomiting kind of off and on since the baby had been born, a little bit of an unusual feeding practices. And the baby historically at 3 months of age had had this spell where the baby was sick and seemed to have a seizure, possibly, but was well or appeared fairly well in the emergency department and was sent home. So here you can see bruising on the scalp, which is a little bit faint, but even one of these would raise a concern for fingertip contusions, and you can see that the baby looks a bit thin. When the baby was eventually worked up, this baby had a liver laceration, some healing rib fractures, and skull fracture. And I apologize, that's not projecting as it should. Here's a 3D CT scan of the chest, and you can see a healing rib fracture here and several others. You can also see a skull fracture here and here. Ultimately, the mother's boyfriend pleaded guilty. So these cases, we know about a third are missed. The recommendation is that clearly for an infant presenting with a sentinel injury or a history of a sentinel injury, they should be worked up for occult injuries, including abusive head trauma. They should be usually reported to law enforcement and child protective services unless there's some sort of medical cause of the sentinel injury found. And then if there's just a report that the infant was shaken or slammed, but the infant looks well, those infants should still receive a complete workup and report. This was a case that illustrates that, but basically it was a 3-month-old where there was a history that the mother had shaken the baby, but the baby on exam looked completely normal. There really was nothing, and the baby otherwise looked fine, other than this history. And so a workup was actually performed, and this baby had what we call classic metaphyseal lesions, or CMLs. But this is a fracture type or broken bone that is highly correlated with child physical abuse and can be seen in these kinds of cases. I'm turning to the question panel. It looks like I have one. Um, it is a question about where can we get good free handouts for parents on how to deal with crying. I think that's a great question because coping with crying is something that is a great strategy for preventing sentinel injuries, for preventing parental frustration, and for preventing abusive head trauma. And I would steer you to the Child Abuse and Neglect Prevention Board, or the Children's Trust Fund is what they used to be called in Wisconsin. It's now known as the Prevention Board. So if you just look on the internet for Wisconsin Child Abuse and Neglect Prevention Board, you'll find their materials and training. You can also go to Period of Purple Crying, which is the recommended curriculum for new parents in Wisconsin, and it has an extensive segment in that curriculum to teach parents how to cope with crying. So I'm going to continue now. So why are young children vulnerable? Why do we just see this in infants and young children? And it goes to that size factor, but also some immaturity of the tissues. And so the head is proportionally larger and heavier, the neck weaker, the brain itself has a higher water content in younger children, and so it's more susceptible to injury. The smaller immature blood vessels are more fragile, and babies and young children don't have the strong protective reflexes that you and I have if somebody tried to shake, slam, or otherwise abuse us. So how vulnerable are they? Well, we know we don't see these injuries in the normal care and handling of an infant, and we actually don't see them even in short household falls or most unintentional injuries, except for very severe force like motor vehicle crashes. We're talking about much more than just jiggling the baby or playfully playing with the baby. If the baby appears to be enjoying an activity, you can be assured that they are not suffering injuries like abusive head trauma. So what are the injuries? Well, I've talked a little bit about them. The brain injuries, we actually, although I'm showing you a head CT, it's really a clinical diagnosis. So it's taking a careful history because we know that the head CT or even MRI can be completely normal in cases where there is severe primary diffuse brain injury. That being said, we're doing the head CT in suspected cases, not so much to look for brain injury, of course we're doing that, but primarily to look for bleeding on the surface of the brain, which is almost always present. So the head CT is performed by taking a series of cross sections, such as illustrated right here. It is a type of X-ray, and it does use radiation. It does not hurt, and it is very quick. An MRI does not use radiation, which makes it better, but it is not fast. It's very noisy. It is not easily performed in an infant or a small child who won't hold still, and usually requires sedation. So a head CT is usually the first study that is performed. And what they are is a series of cross sections. This is actually looking at a coronal section, so it's a little bit different slice, but it's basically a slice of the head is what we're looking at. And so you can see here the axial slices are illustrated by these white lines through the skull or through the brain of this child. And this is a really normal looking head CT on this baby where you can see the soft spot. So this is the front of the baby's head, and there's the soft spot where there's no bone because the bony plates are not yet grown together. You can see these normal sutures where the bony plates come together. Most of the skull is you can see quite easily. And then you can see all of the rest of this is brain, or most of it is brain. And you can see these little finger-like projections. These darker areas are actually the white matter, and then these lighter areas are the gray matter, and this looks really normal. If you have swelling or tissue injury here, what you'll lose in some cases, especially in very, very severe cases, you lose it quickly. And in other cases, you may lose it after several days, but you can lose that gray-white differentiation or these finger-like differences between gray and white matter because of all of the swelling. So here is a CT scan of a baby who has been abusively head injured, and you can see this kind of white, it looks white on here, fluffy material near up underneath the skull. And what that is that subdural and probably some subarachnoid bleeding. You'll also see the brain itself looks kind of just solid gray. You don't see those finger-like projections, and that's because there's been diffuse, very severe, both primary and secondary brain injury. And then as it swells, the very sad thing we see in severe cases of, the most severe cases of abusive head trauma is the brain as it swells doesn't have any place to go. And you'll see it herniate. Basically, some of the brain kind of squishes out through the brain stem where the vital centers of breathing and heart rate are, and lead to death of the child. And so we, sometimes you'll see it, it's illustrated here, but it'll cause the sutures or those bony plates to move apart because the brain is swelling and essentially forcing those apart. So it's not just head injuries that we see in these children, but you can see a variety of other injuries. And about half of all abusive head trauma cases have other outside of the brain or outside of the head injuries. And the reason why that is because some of these kids have been abused in a variety of fashions. So their arms or legs have been yanked on, or they've been poked at, or objects forced into their mouths, so they can have mouth injuries. But sometimes it's the actual act of shaking, slamming the child that causes the arms and legs to be flung violently back and forth that can cause those CMLs or those corner fractures to happen. We know that these kids can also have, in addition to fractures, they can also have retinal hemorrhages, and I'll show you that in the next slide. But you should keep in mind that if all you have is the brain injury with bleeding on the surface of the brain, you can still have a diagnosis with reasonable medical certainty of abusive head trauma, but it takes really some expertise, and it takes consideration of what else could this be medically. We call that a differential diagnosis to make that diagnosis with medical certainty. So here's just another illustration of the retinal hemorrhages that you can see. Here's the eye. This is the lens of the eye. This is the optic nerve in the back of the eye that attaches. It's actually part of the brain. And the inside where the jelly or the vitreous is. And the jelly in very young infants is very firm. And so as the globe is being shaken, slammed, or thrown, it's moving at one rate, the jelly, the vitreous at another, and you can see tractional forces or pulling forces, shearing forces that result in the bleeding that can be seen, which is illustrated here. And this is what they look like if the doctor looks directly into the pupil, and they can actually be seen with some special equipment if you look into the pupil. Some of these babies will also have, or children will have, rib fractures from severe squeezing or anterior-posterior compression of the chest, which is just illustrated here. And you can see it here on the x-ray. This child has healing rib fractures. The reason we do two parts of the skeletal survey is these fractures can be really hard to see, but you can see once they've had a chance to heal, they have this bony callus is what it's called, but they look like bony globs on the ribs as they heal, and they're much easier to see. And then I've already mentioned that some of these kids will have these fractures. So the fingertip contusions, or where the child was grabbed around the chest, we don't see these very often, not even when we have acute rib fractures, but this child did have at least several that are illustrated here. So how do we diagnose it? I've mentioned this, but basically it requires some special expertise. It involves looking for associated injuries, but it also requires having kind of the injuries that I've mentioned, but it also requires that other potentially accidental history, so that would be like a motor vehicle crash, usually involving such severe forces that these would be well witnessed, police called to the scene. We're not talking about your typical fender bender here of severity, but also no evidence of some sort of underlying disease that could explain the findings. And that would be quite rare, but we look hard for them at, at centers that have specially trained physicians. We look for those. The timing becomes really important, and so this is where investigators can help a lot. But as I mentioned, with a concussion, these are like very, very severe, much more severe than your typical concussion. But these babies and young children are immediately and persistently symptomatic. And so getting that careful timeline is really important from anybody who has seen the baby. And you need the details. You want something more than just that the baby was fine. You want to know exactly what the baby was able to do and how normal this baby was. So getting concrete examples of how the baby was behaving can be quite helpful. So I've mentioned this, but you want to get that timeline, but you also want to ask about any unintentional injuries. And of course, the birth history becomes important, particularly in these very young infants with possible abusive head trauma. So the prognosis is that all of them have had a brain injury. And as far as we know, it likely has impacted their life course trajectory in all cases. About a quarter or so will die. About a quarter are really left with a brain that looks a lot like this, where this is just fluid. And what little is, this is fluid here, and what little is left of the brain, these kids are quite devastated. So what we see are these developmental delays in these more severely impacted or severely affected children. They can look a lot like a cerebral palsy kind of situation, but they almost always also have a cognitive deficit. They can be spastic. They can have blindness, usually from the brain injury, not from the retinal hemorrhages. Seizures. They can be left with hydrocephalus or water on the brain. You should keep in mind that some of the babies or young children will initially do fairly well, where they seem to recover. And we should always be careful or cautious about what we say, because you can get fooled into thinking that, oh, the child is actually going to be fine or normal. Keep in mind that these babies universally have diffuse primary brain injury, and that their life course trajectory will never be the same, although it's impossible sometimes to show how that was different, because some of these children, about a quarter or so, will do fairly well. So I've included some references throughout the slides and footnotes, and I've also included some in the reference page. And I will turn to the question panel here. I have about a minute and only one question. So when obtaining a timeline, how far back in time should information be obtained? It's a great question. There's not a simple answer. If we have the medical provider, if they think that there's been only one acute event, that's acute meaning like right before the child presented for care, and there's no indication of previous events, so like no healing rib fractures at the time the child comes in, or no history of the child being unresponsive or very, very sick where it may have been a missed case. If you think that this is just a single one-time event, which you'd have to get from the medical provider, then the timeline should go back to at least 2 to 3 days before the child became clearly and persistently symptomatic. and that gives you an ample cushion to talk about the baseline and how well this child was doing before the onset of symptoms. So there are no more questions, and we have just reached 1 o'clock. I thank all of you very much for your attendance and also for your patience as the medical college is transitioning to a little bit different software for continuing education credit. So I know Kathy at Ardolini in our office is working to try to make the continuing education a little bit easier, but for the next several sessions, we're likely to have a little bump in the road in claiming credit. I want to encourage all of you, please fill out your evaluations. I take those very seriously, and all of our presenters use your comments. Thank you.